The Micro Mini Gracie curettes feature the great benefits of the Mini 5 curettes with 20% thinner blades. This is beneficial for accessing narrow subgingival spaces, furcations, and root concavities. The Micro Mini 5 1-2 adapts well to the narrow root anatomy of anterior teeth while reducing traumatic tissue distension. The Micro Mini 7-8 is great for accessing the buccal and lingual aspects efficiently. The Micro Mini 5, 11-12, and 13-14 are ideal for accessing molar anatomy with ease.
Demonstrate the use of 4 different great instruments for deep palatal pockets. The first one is a mini bladed Gracie, and Hugh Freedy calls this the Mini 5, but many other companies make mini Gracies now, and I'm using a 5-6, but you might choose a 1-2 in this series, and you can use this on the direct palatal and then rotate around and use straight vertical strokes, either overlapping or longer vertical strokes coming out of the pocket like this. Now, one of my personal favorites is this one, the Micro Mini. The Micro Mini is 70% smaller than a Gracie, really thin and wonderful for deep palatal pockets on any of these teeth, but really great for the anterior palatal like this. So this is the Micro Mini Gracie 1-2. So you can do overlapping strokes or you can do longer strokes with this. It adapts very well to the anterior teeth. I'm now going to show you 2 different instruments called the Gracie Curvette Sub-Zero. This is a heftier, stronger instrument with a stronger shank. You can use it on the direct palatal or rotate around. This will scale 360 degrees around an anterior tooth. Has great adaptation because of the extreme curvature of the blade. This version, this is Hugh Freedy's version of the Sub-Zero, has the extreme curvature of the blade and also has a 5 and 10 millimeter marking. So you would use this like this, insert subgingivally, adapt to the palatal, use strokes on that sheet of calculus, or might be a small ring of calculus. And again, you can use overlapping short strokes to begin with, and then I would finish with longer, more even strokes in that deep pocket. And this will remove a thin sheet of burnished calculus, or if you have lighter, crumbly calculus, it will come off very, very easily with this instrument. I'm going to show you 2 traditional approaches to scaling deep pockets on the palatal aspect on the maxillary right side. I'm in a 1 to 3 o'clock position on the left side of the chair. Patient's head is way back, and I'm approaching this with the fulcrum on the buccal of these teeth, and I'm taking a Gracie 7-8. Now this could be a universal curette or it could be a Gracie 11-12 possibly. But when you do this horizontal stroke, you're really contacting this root with a very sort of a straight blade against a very curved surface. So you get very little contact as you do horizontal strokes like this on the palatal. It's not an ideal way to scale this. Some people like to use a Gracie 13-14 and they feel that the curvature of this gives them better access when they go subgingivally. But still you're using sort of a curved blade and very short strokes against a curved root surface here. Especially on the premolars, this is a very difficult area to scale, and so traditional universals and Gracies are not the best choice. Instead, I'm going to show you 2 great choices. First, the Mini 13-14, and I'm going to adapt this with the blade directed distally, fulcruming here in the anterior area. You insert and you can scale on the premolar like this and rotate around. You can do the premolars very easily or nicely, and then when you get to the molars, again, insert subgingivally and with the blade directed distally, with a close intraoral rest here, we're going to go around, and you can also scale deep pockets on the distal with this mini 1314. Now, an even better choice than this mini, in my opinion, is the new Micro Mini 1314, 70% smaller than a Gracie, a very sharp, very strong blade that goes subgingivally, and you can go like this on the premolars, going into tight, deep pockets. Even if there's sheets or rings of calculus, this will engage the calculus very nicely. And then again, this is with the blade directed distally. You can do strokes on the palatal and the distal of all of these molars and premolars from this position, from the 1 to 3 o'clock position on the left side of the chair. Here's an extreme close-up of the Micro Mini 1314 blade directed distally. I'm going to insert into this deep pocket and then use vertical strokes, rotate around the line angle. Now I'm doing the distal with this Micro Mini. You can use the same technique with the Mini 1314. Just direct the blade distally, use a close intraoral rest, use a lot of pressure from your thumb to engage the blade, and then use your thumb to rotate around the distal line angle, and then you can use strokes to do deep distal pocket areas as well. Let's do the last one. I'm fulcruming toward the buccal cusp, using my thumb to adapt this blade. Make sure the 1314 mini or Micro Mini blade is directed distally, and then go all the way around into the distal pocket area. Most clinicians traditionally have used Gracie curettes or universals for this. Let me show you the size of a Gracie 11 blade, 12 blade. To scale this furcation, you can see that you can enter, but when you're fully in, this is a very, very long and large blade. Many times it will not even reach the ceiling or clean it because it's too wide. Also, some people like to use a universal curette. This is a Columbia 4R 4L. Again, a very large blade. Look at the size of this. And so using conventionally shaped instruments, the universals and the Gracies, most of them many times are just too large to do a good job in here. And if I take a Barnhart, for instance, this is a little bit smaller bladed Barnhart. Even this, when you go inside the furcation, I can feel that I'm getting stuck and it's not doing a thorough job. When we look with the dental endoscope, we can see almost 100% of these furcations have calculus left right here on the ceiling, in here, and various places on the root. And most of it is because people are using haphazard strokes and they're using instruments like this that are much too large. Ultrasonics often leave burnish calculus also, so practice with the Micro Minis, the Catans, and the Diamonds. To scale the buccal furcation on a maxillary molar, I'm going to use a Micro Mini 1112. This is 70% smaller than a normal Gracie 1112. And I'm going to start here and go right into the mesial aspect of the distal buccal root with this instrument. Now I can use an extraoral rest if I want to just deplaque, but if I'm trying to get some pressure and scale here, I'm going to use an intraoral rest with this blade. To scale the distal furcation of the maxillary first molar, I'm going to approach with an intraoral rest with the Micro Mini 1314. Now this furcation should be scaled from the buccal aspect. I'm going to do both aspects of the furcation from the buccal. So here's the Micro Mini 1314. I'm going to go up and rotate this blade. I'm in. Okay, now I'm going to scale the palatal aspect of the distal buccal root with this Micro Mini 1314 blade. And then I can use the toe of it like this to pull out in a distal direction and gently debride the base of the furcation. I'm going to demonstrate the scaling of the buccal furcation on a mandibular right molar from the buccal aspect with a Micro Mini 1112 to begin with. This is a Micro Mini Gracie 1112. Scaling the mesial aspect of the distal root. And then you can use the toe to scrape a little bit here, scale a little bit on the ceiling of that furcation. Micro Mini 1314. Now these Micro Minis are 70% smaller than a regular Gracie, and so you adapt this, go subgingivally, and then begin your strokes here toward the buccal, and then rotate around. And now I'm adapting to the distal surface of the mesial root. And then here we're going to use the toe of this, and I will lift the handle out a bit so that I can use the toe of this to scale the ceiling of the furcation. Here's a little different view of this 1314 Micro Mini. I want to show you how that tip is used to pull out. You lean the shank and the handle out away from the arch and then use the toe of this to scale and clean out the sealing of the furcation. Now you don't want to be too aggressive with this. You use light to moderate pressure. If you go too aggressively, there's only 1.5 or 1 millimeter of dentin between the outside of the root and the pulp chamber. So you can actually get a pulp exposure if you use any instrument to scale too vigorously. I want to demonstrate the scaling of a lingual furcation involvement. Now this is almost the same as scaling the buccal aspect or a buccal furcation on the lower right. I'm doing the lingual furcation on the lower left first molar. I have an intraoral rest, and this is a Micro Mini 1112. You can use a Mini 1112 or this Micro Mini, which is even smaller. So we're going to start and do overlapping strokes here to scale the mesial of the distal root. And then when we get to the ceiling of the furca, you just use the toe of this instrument to pull out, and gently, you can do this with a light stroke or a moderate stroke. You don't want to go too aggressively because you can go right through the dentin there. It's only about a millimeter and a half to the pulp chamber. So you want to do this carefully. Now, this is the 1314 Micro Mini, 70% smaller than a regular Gracie. It's smaller than the Mini even, and we're going to go down subgingivally with this, and we're going to rotate around and scale the distal of the mesial root. So as you go in, you lean the instrument toward the lingual in order to reach in, and then to do the sealing of the furca, I'm going to insert this and then pull out with the toe. This is the smallest instrument or the smallest curette that you can use for scaling of a furcation, far superior to conventional instruments, and we have used these now for over 5 years. The regular minis came out 20 years ago, 1990s. And the Micro Minis were introduced in 2005. So both of these mini-bladed instruments have been available for quite some time. Instrument is something called a Catan furcation curette, and I'm going to use the buccal end of the Catan. This is a small hoe. Look at the end of this. It has a small round half circular, semicircular, moon-shaped blade, and it fits right in the furcation. You lean out and you pull out with this blade. This is designed specifically for the furcation. A safer instrument to scale the base of that mesial furca is something called the Catan furcation curette, and this is actually a hoe instrument. You see, it's a very tiny hoe. And this is the mesial end. So you adapt this. I'm going to use an intraoral rest right now. You adapt this to the root. Usually if you're scaling here, the tissue will be somewhat loose in a furcation area, especially if you have a lot of calculus here. So you use this, and then I'm going to lift up a little bit This might distend the tissue, but if you have some recession and some loose tissue here, you can go all the way back as far as this furca goes in to clean out the base. The purpose of this video is to illustrate the width of stroke of various hand instruments and some ultrasonic unit tips also. I've got a collection here, and you should also try to obtain some extracted teeth and paint them with either this black airplane model paint, or you can use fingernail polish. I'm going to move these away so I can hold this molar and show you how I'm going to use a Gracie 1112. Let me hold this as if it's in the mouth, and I'm going to fulcrum on my finger here and lay the 1112 blade against this tooth as if I'm scaling this mesial surface. So lay the blade in here, and then I'm going to make one good stroke, and you'll see about the width of a stroke. Let me do that again. The width of one stroke with something like a Gracie 1112. Even if I try to lay this against the tooth, it might hit in two spots like that, two places, but generally it only hits in one spot like this. A very small area of the blade will actually remove biofilm or calculus. So this is why when we do instrumentation, you need to do overlapping strokes like this. And generally you work from, when you're in a pocket, you're working from the midline or the middle of the tooth across to the opposite side. Like in this instance, it would be toward the lingual side. In order to remove the rest of the biofilm or calculus, you would have to turn an 1112 over, come into the pocket, then you start in the middle somewhere, and then you scale. I'm scaling from the lingual aspect, but I'm going toward the buccal, you see, and completing the buccal half of this. So you have to do overlapping strokes. Now, let's take a look at another tooth with a different instrument. Here's a close-up of a Gracie 1314, and I'm going to adapt it to the distal surface. Now, the 1314 seems like a big blade that curves around and hugs a lot of the tooth. This is what a 1314 blade will do. It does about that much with each stroke. So if I advance it and do another stroke, I run the risk of missing something in between. So once you're in a pocket or once you're scaling, you have to do overlapping strokes. Watch what I'm doing. Overlapping strokes, only moving forward about 1 millimeter at a time with each stroke. Even then, it's often common to miss areas in between strokes. Now, if we come in from the other side now with the 1314, we start right about in the middle. Even though you try to adapt the whole thing, only about the first millimeter of the blade is going to actually contact the curvature of the root. It is the curvature of the root, the anatomy of the root, that dictates how much is coming off with each stroke. So you have to carefully adapt this. It's basically a straight line with any kind of a bladed instrument. It's a straight line hitting a curved root that's either convex or concave. So the strokes have to be very carefully placed, progressing 1 millimeter at a time across the tooth surface, overlapping and very close together like that. Let's look at the width of stroke now with a mini 1112. This is half the Gracie blade length and thinner. And you'll see that when you go into a pocket, this is a shorter blade, so it adapts really well to the anatomy of the tooth. We'll adapt this in the pocket as if we're in a deep pocket, and let's do one stroke. See how tiny this width of stroke is, but it's the same as a Gracie, as a universal, as almost any hand instrument. Everything removes about the same width of stroke because it's the curvature of the tooth that's dictating what comes off. So we do overlapping strokes with this mini across the surface, and we run less risk of spanning across depressions or lacerating tissue as we go across toward this line angle. Let's flip it over. Once the mini is in the pocket, you see if you start here at the midline, because it's shorter, you can do overlapping 1mm strokes, just as you would with a larger Gracie or a larger Universal, but it's very precise in its adaptation to the anatomy of the tooth. So even if it's half the blade length, it's very efficient in adapting to the tooth contours, and you get about the same width of action or the same blade width with a mini as you do with a regular Gracie or Universal. Okay, I have an anterior tooth here, and I'm going to come in with a Gracie 5/6. You'll see how big this blade is on the proximal surface, and we'll lay it down and do one stroke. That's about what this does. Now if I lay it really flat, let's see if we can get more of it to contact. Yes, it's hitting the contact, the height of contour here of the root, but the depressed developmental depression part of the root, you see, is not contacted at all by this Gracie. So this is one of the disadvantages of scaling with a bigger blade, like a Gracie. This is a 5/6, or the 1/2 would be the same size. Even a small universal curette, or let's take an average size universal curette. This is a universal curette. It's going to do the same thing. It's just going to hit the high spots and not be able to negotiate the depression unless you back up, and you see then you're off the tooth. Unless you have really loose tissue, you're just not going to hit that area. So what do? Here's a micro mini. These are new instruments. They are 70% smaller than a Gracie and thinner. Here's the blade, and I'm going to adapt that, and you'll see what this is able to do. So with overlapping strokes with a micro mini, you can go this way, and I'm into the depression now. I'm going to flip this over and come from the other side and then adapt this to the depression in order to completely scale out the depression. So this is a very tiny, sharp blade that adapts very well to the contours of the tooth. I've got to get it really parallel though, so that it'll really go into this area. Okay, now the advantage of this instrument is really obvious for the anterior teeth especially, and for areas like furcations. But let's look at the lingual of this tooth, and you'll see on the lingual that if I get this micro mini, I can start on this lingual and do overlapping strokes, and it will remove calculus very carefully, you see, without impinging on the tissue. Also at the CEJ, you can do very, very short overlapping strokes, or you can do a bit of a horizontal stroke with the toe like this, right at the CEJ very carefully, and it will remove the calculus right at the CEJ. So something like this that's very small is important to adapt to the tooth. There's another instrument that I'll show you on the facial of this same extracted tooth, because all of these anteriors are very narrow. So there's an instrument called a Sub-Zero. It's a Gracie Curvette Sub-Zero. Several companies make this, and it adapts really well to these very narrow surfaces. So I'm on the facial here, and it's got an extreme curvature to it. So it's half a Gracie blade and thinner and curved. Very, very acutely curved around. And as I said, this is made by several different companies, but it's a really excellent instrument for anterior teeth. I'll go around and then do a proximal surface with this as well. This is the Sub-Zero, and you'll see how quickly this will adapt to the tooth. I'm going to come around from the other side with the Sub-Zero and then show you what we can do with this instrument. Very, very quick to adapt and very efficient in scaling line angles, linguals, facials, and proximal surfaces. Now here's another molar, and I'm going to illustrate how a universal curette will perform. I'm going to lay this universal curette blade on the tooth and see what the width of the stroke looks like with this. You see that it does about 1 millimeter width. Even if I lay it very, very close to the tooth, it hits the high spots, so it'll do a millimeter here, a millimeter there. And if I do overlapping strokes in the same spot, that's what's going to happen. So you're going to have to move this blade, and even if I move over here and try to do this whole thing, you see it's not going to cover everything. You've got to use the lower third of the blade and do overlapping strokes. This is a universal curette now to go across a surface. I'm going to flip it over. Then you have to come from the other side, and that stroke actually starts somewhere near the midline, and then you'll pick up the buccal half of that tooth or that mesial surface like that. Now, even if you do this, you see you can never remove 100% of the biofilm or the calculus. There's always some embedded areas, and we'll look at ultrasonics to see what the potential is for a stroke with the ultrasonic scaler. Now let's take a look at a tooth and a Nevi sickle. It's a curved posterior sickle, and we're going to stay fairly superficial here because you might use this under the tissue, but you will probably be on the crown of the tooth. And let's see what the width of stroke is with this instrument. So even though it's a gigantic or pretty big blade, you see that each stroke only removes, again, about a millimeter, starting at the midline of the tooth and then going toward the lingual surface. So again, it's a straight cutting edge hitting a curved surface. Let's flip this over and come around from the other side, and then we would start somewhere near the middle, and then again you have to do overlapping strokes over to the other side. So this is whether you're on the crown or on the root. Any blade, sickle, curette, Gracie, universal, they all are just going to hit the tooth on a tangent and remove a small amount. Ultrasonics do exactly the same thing. So we'll take a look at the ultrasonics in another segment.
This is an advanced method for hygienists if they want to use their 17-18 in a different kind of unconventional manner to get the distal line angle of the second, behind the second molar, and it's extremely hard to get the distal furcation back there. With the amazing Gracie, the 17-18 Gracie, you have a long enough length to be able to get this line angle comfortably on the patient with the retromolar pad back there and dip it into the distal furcation and clean that out as well. And you know you're in the right spot if you look down on the top of the second molar and you see the letter L. Then you know you're in the right spot.
2, 3.
One area that hygienists have trouble reaching and sometimes is missed with calculus is the mesial of the first premolar. If you see the indentation fossa area on the typodont tooth here, you can see the nice straight long indentation line. That's hard to reach in the patient's mouth. We take the Nebraska 128. It has the same kind of long straight edge able to get into the mesial of that area quite nicely. Clean that all the way up and down real easily, being right out in front of the patient as you're doing it. You can do that on the buccal side and the lingual side, real comfortable for the patient.
There are 4 standard inserts commonly used during initial gross debridement procedures: the Cavitron FSI 10, the Cavitron FSI 100, the Cavitron FSI 1000, and the Cavitron FSI 3 beaver tail. The standard diameter inserts are specifically designed for efficiently removing moderate to heavy deposits. This is the Cavitron FSI 10. It is designed for removal of moderate to heavy deposits, and it can be utilized at all power levels. The Cavitron FSI 10 has a straight shank and can be used on all accessible tooth surfaces. After the clinician has filled the handpiece with water, seated the insert, selected the power, and adjusted the spray properly, instrumentation begins according to the treatment plan prescribed for the patient. The clinician begins by adapting the lateral surface of the Cavitron FSI 10 on the clinical crown and activates the foot pedal to begin the stroke. Adaptation will be in the transverse oblique approach in the healthier sulcus to prevent encountering the junctional epithelium, and in a more vertical approach as indicated. The clinician adapts 2 to 3 millimeters of the terminal end and rides the anatomy towards the gingival margin in a vertical oblique orientation while maintaining an angulation of 0 to 15 degrees. When calculus is encountered, tap at the deposit in a multi-directional approach. Microfracturing the deposit and following with 2 to 3 millimeter sweeping strokes to flush the sulcus disrupts the biofilm and allows the clinician to assess the success of this technique. These steps should be repeated in a methodical, channel fashion, ensuring complete removal and thorough biofilm disruption. This is the Cavitron FSI 100. It is designed for removal of moderate to heavy deposits and can be utilized at all power levels. The Cavitron FSI 100 has 2 bends to the shank facilitating access to posterior teeth, aiding in adaptation. After the clinician has filled the handpiece with water, seated the insert, selected the power, and adjusted the spray properly, instrumentation begins according to the treatment plan prescribed for the patient. The double bend shank of the Cavitron FSI 100 allows the clinician to easily adapt this insert in the posterior region. This feature provides access into deeper pockets of the interproximal spaces where heavier deposits may be encountered. The clinician begins instrumentation by adapting the lateral surface of the Cavitron FSI 100 on the clinical crown and uses the back and/or face of the insert tip as needed. The clinician demonstrates a transverse oblique approach, maintains 2 to 3 millimeters of adaptation, and 0 to 15 degrees angulation. The clinician continues scaling and demonstrates strokes in the horizontal, transverse, and vertical orientation to fracture and remove deposits. Utilizing an overlapping methodical stroke pattern is essential to achieve thorough removal of biofilm and calculus. This is the Cavitron FSI 1000. It is designed for removal of moderate to heavy deposits and can be utilized at all power levels. The Cavitron FSI 1000 has a triple bend and in cross-section is shaped like a square. Energy is dispersed from this design in a more powerful way due to the cornered cross-section, aiding in effective removal at the line angles and interproximal surfaces. After the clinician has filled the handpiece with water, seated the insert, selected the power, and adjusted the spray properly, instrumentation begins according to the treatment plan prescribed for the patient. The clinician utilizes the Cavitron FSI 1000 insert for deposit removal along the line angles and interproximal surfaces where heavier deposits are present. The clinician will start by adapting the lateral surface of the Cavitron FSI 1000 on the clinical crown and uses the back and/or face of the insert tip as needed. Utilizing a transverse orientation, maintaining 2 to 3 millimeters of adaptation and 0 to 15 degrees angulation, the clinician utilizes strokes in the horizontal, transverse, and vertical orientation to microfracture and pulverize the deposits. Adaptation of the terminal end is essential for effective removal and protecting the tooth surface. Thorough biofilm removal and calculus is achieved with an overlapping methodical stroke pattern. This is the Cavitron FSI 3 Beaver Tail. It is designed for removal of calculus bridges and removal of heavy stain and can be utilized at all power levels. The Cavitron FSI 3 Beaver Tail has a rounded toe design which enables clinicians to adapt the toe for removal of heavy deposits in larger pieces and sections. After the clinician has filled the handpiece with water, seated the insert, selected the power, and adjusted the spray properly, instrumentation begins according to the treatment plan prescribed for the patient. The number 3 beaver tail will be demonstrated on the mandibular anterior region. The beaver tail insert is utilized for the removal of heavy deposits in this area. Once the foot pedal is activated, the clinician approaches the deposit in more of a straight-on approach due to the blunted tip of this insert. Adapting the insert under the deposit allows the calculus to break free in large pieces, allowing for more efficient removal. There is a slight vertical stroke when a ledge of calculus is lifted from the tooth. There are 4 inserts in the slimline family commonly used during periodontal debridement procedures: the Cavitron FSI Slimline 10, the Cavitron FSI Slimline 1000, the Cavitron FSI Slimline Right Curve, and the Cavitron FSI Slimline Left Curve. Following an initial gross debridement, the clinician will follow through with a finer debridement to ensure removal of lighter calculus, remaining biofilm, and endotoxins. The Slimline series are designed to be utilized for patients that present light to moderate calculus and tissue topography and/or pocket depth which call for a slimmer diameter insert for access. This is the Cavitron FSI Slimline 10. It is designed for removal of light to moderate calculus and deplaquing and should be used at low to medium power levels. After the clinician has filled the handpiece with water, seated the insert, selected the power, and adjusted the spray properly, instrumentation begins according to the treatment plan prescribed for the patient. The clinician will adapt either the lateral or back surface of the Cavitron FSI Slimline 10 to the clinical crown and float towards the gingival margin, maintaining 2 to 3 millimeters of adaptation and a 0 to 15 degree angulation. Depending on the patient presentation, the clinician will enter the sulcus or pocket in either a vertical or transverse approach. For demonstration purposes, we are utilizing the vertical approach for the patient with deeper periodontal pockets. As the clinician enters the sulcus, it is essential to assess the anatomy as the insert travels to the base of the pocket. If calculus is encountered, the clinician engages the terminal end of the deposit in a light tapping approach, followed by small sweeping strokes to provide lavage and assess the removal. It is imperative to ensure the complete removal by producing a stroke pattern that is overlapping and methodical. Haphazard strokes will leave the surface incomplete, contaminated, allow for biofilm to attach, and harbor the pathogens we are attempting to rid from the pocket. As the clinician moves toward the interproximal area, it is important to angulate the insert so that 2 to 3 millimeters of the terminal end is always adapted. Following the vertical orientation, the clinician will adapt in a transverse approach under the contact areas for complete debridement interproximally. Knowledge of each area of anatomy is essential for successful removal of calculus. A thorough periodontal charting and accompanying radiographs are also essential tools for effective ultrasonic instrumentation. This is the Cavitron FSI Slimline 1000. This insert combines a slim tip with a triple bend design with beveled edges, allowing for better adaptation around line angles and can be used at all power levels. After the clinician has filled the handpiece with water, seated the insert, selected the power, and adjusted the spray properly, instrumentation begins according to the treatment plan prescribed for the patient. The Cavitron FSI Slimline 1000 can be adapted at the line angles, the root concavities, and interproximally as well. The clinician will start by adapting the lateral surface on the clinical crown and uses the back and/or face of the insert tip as needed. Strokes may be performed in a horizontal, transverse, or vertical direction as long as the clinician is methodical and covers every square millimeter. This is the Cavitron Soft Tip Ultrasonic Implant Scaler. This insert gently removes light to moderate plaque and calculus without damaging implant titanium abutment surfaces and should only be used at low power level. The implant insert is manufactured and designed to be utilized with a corresponding soft tip disposable prophy tip. This tip is removable for one-time use and may not be used on any other insert. The Cavitron Soft Tip Ultrasonic Implant Insert should never be used without the soft tip disposable prophy tip. To prepare the Cavitron Ultrasonic Implant Insert for use, take a new plastic soft tip disposable prophy tip and place it point first into the hole in the end of the wrench. Insert the metal tip of the insert into the opening of the prophy tip and twist 1/4 turn while applying firm pressure to securely seat the disposable prophy tip on the metal insert tip. Disengage the prophy tip from the wrench and gently pull on the prophy tip to verify that it is securely in place. After the clinician has placed the soft tip disposable prophy tip with the wrench included, filled the handpiece with water, seated the insert, selected the power, and adjusted the water flow to obtain a fine spray, instrumentation begins according to the treatment plan prescribed for the patient. Dental implants and their titanium surface need additional consideration when choosing the proper debridement instrument. The sulcular environment and the mucosal seal is more fragile than the normal tooth, and this requires a gentle approach and care when debriding in the sulcus. The insert terminal end is placed slightly subgingivally with a 0 to 15 degree angulation and 2 to 3 millimeter adaptation. Utilizing a 1 to 2 millimeter overlapping stroke will ensure thorough biofilm debridement. To prepare the insert tip for sterilization, keep the insert in the handpiece and place the tip into the insert in the slot on the wrench. Place your thumb and index finger over the disposable prophy tip. Gently push the handpiece downward and the tip will disengage. Discard the used plastic soft tip disposable prophy tip in accordance with applicable standards for disposable biohazard materials. Proceed with sterilization of the ultrasonic insert and soft tip wrench. It is recommended to always sterilize the insert and the This is the Cavitron FSI Slimline right and left curve. They are used for fine periodontal debridement in deep pockets greater than 4 millimeters. Utilizing these inserts provides maximum access and adaptability to root anatomy, including concavities and furcations. These inserts should be used at low to medium power levels. After the clinician has filled the handpiece with water, seated the insert, selected the power, and adjusted the spray properly, instrumentation begins according to the treatment plan prescribed for the patient. When access is indicated in deeper pockets, in particular the posterior teeth, the curved insert is often necessary to maintain true adaptation of the terminal 2 to 3 millimeters at all times. A review of dental anatomy is recommended so the clinician is familiar with the topography of the different molars and the corresponding concavities and convexities. Understanding the area-specific design of these inserts is essential for proper adaptation. The clinician must be able to identify the inserts by recognition of the shank and direction of the curvature of the tip. Memorizing colors or trying to read the stacks can be challenging and prove confusing for the clinician. Adapting the curved insert properly requires a fundamental knowledge of the tooth's anatomy and proper placement on the appropriate tooth surface. In order to identify which insert one is holding, it is recommended to begin by holding the inserts parallel to the floor with the points facing down or perpendicular to the floor with the points facing away from the clinician. The right insert will curve to the right and the left will curve to the left. It is also helpful to place the insert on the occlusal of the intended tooth, as demonstrated here, to see the curvature to ensure you selected the correct insert. After this is established, maintain a vertical approach and notice that the back of the insert is adapted to the surface you are entering. Utilization of all surfaces is indicated for proper adaptation in periodontal pockets interproximally. Begin on the clinical crown, float subgingivally, riding the anatomy and clinging to the pellicle while always maintaining 2 to 3 millimeters of adaptation and no more than 15 degrees angulation. Navigating the pocket, assess while entering and engage any deposit encountered with a gentle tap. Frequent, methodical, overlapping strokes are essential in the periodontal pocket to detoxify and debride every square millimeter. A haphazard approach will leave deposit and biofilm behind and limit the patient's response to therapy. As the clinician proceeds towards the interproximal area, proper adaptation is achieved by staying with the anatomy and following the topography of the pocket. Once thorough instrumentation has been achieved, the clinician returns to the line angle and with a vertical adaptation proceeds with channel stroke across the buccal, allowing for tactile sensitivity to drive the stroke engagement. As seen here, the curved left insert is following the anatomy into the furcation and is maintaining the necessary 2 to 3 millimeters of adaptation. Proper adaptation is required to navigate the interproximal space successfully. A slight turn of the insert maintains adaptation around the line angle and assists the clinician to successfully debride the periodontal pocket. To debride the lingual surfaces of the quadrant, the clinician must switch to the left insert prior to beginning instrumentation. It is essential to remember that the contributors to root surface loss are excessive lateral force, incorrect angulation and adaptation, incorrect insert width, and excessive power. Any of these factors may result in root substance loss and create grooves for biofilm to attach. curved inserts are ideal to reach under the contact areas supragingivally in what is known as the transverse approach, similar to using a Nevi or a 204S posterior sickle scaler. The curved inserts can be adapted to the mesial and distal surfaces utilizing the lateral surface of the tip. Note in this demonstration, the clinician is using proper adaptation for transverse approach, supragingivally under the contact.
Today I'm going to show you how to use your right and left ultrasonic tips. The first step is determining which one is the right and which one is the left. And I find it easiest to put both of your tips together like so and make sure that the tips are pointing away from you. You can see that this one curves to the left and this one curves to the right. It's important to remember that just because they're called right and left tips, that doesn't mean that that's where they're used in the mouth. It just determines the bend in the tip. So I'm going to show you first how to use your right ultrasonic tip. Notice my grasp is still a modification of modified pen. The difference is my middle finger is slid up on the handle instead of on the shank. The tip gets very hot, so you don't want to keep your finger on the shank of the instrument. What you're going to do is I'm going to show you transverse orientation first. Transverse orientation is used for the removal of supragingival calculus and very shallow subgingival calculus. Your right ultrasonic tip you're going to use in transverse orientation on surfaces towards on the maxillary right facial and on the maxillary left lingual. Okay? And how you're going to use it is you're just going to use a vertical stroke up and down in the interproximal area. Notice that the tip doesn't go very subgingivally at all. So if you had deep pockets with calculus in them, this would not be ideal for calculus removal. Okay. If I move down to the mandible and I want to show you the transverse orientation on the mandible, we're going to do surfaces away, and I'm going to need my mirror for retraction, tongue retraction, and I would adapt it this way. Again, move it up and down, and then I would also use it on the mandibular left facials in transverse orientation. Okay, now I'm going to switch to the left ultrasonic tip. And when you're using the left in transverse orientation, you're going to use it on surfaces away. So again, for the maxillary right, I'm going to need my mirror for indirect vision. I'm going to turn the head towards me and place the ultrasonic tip like this, and move it up and down in the interproximals. The other place I'm going to use it would be the maxillary left facial for transverse orientation. And again, I'll move it up and down. Now I'm going to show you how to use the right ultrasonic tip in vertical orientation on the mandible. So you would use it on surfaces towards, so that would be the mandibular right facial and the mandibular left lingual. And if you're using it on the lingual, again, you're going to need your mirror for tongue retraction. Okay. Now I'm going to switch to the left tip and I'm going to show you that vertical orientation. we're going to use the left ultrasonic tip on surfaces away on the mandible and vertical orientation. So I would adapt it this way and come across the tooth. Now I'm going to use the left ultrasonic tip and vertical orientation on the mandible for surfaces away, and so I will use it on the mandibular right lingual. Remember, in vertical orientation, you can use several different strokes. You can use a vertical stroke, which is an up and down stroke, a horizontal, or an oblique. And it's really necessary to use all three in order to cover all of the tooth and remove all of the calculus. Now I'm going to show you vertical orientation on the maxilla for the left ultrasonic tip. So we use it on the areas of surfaces away. So you use it on the maxillary right lingual. And you would also use it on the maxillary left facial. And remember, you want to turn your patient's head toward you. Why we switch the tips for vertical and transverse orientation is it's very important that the tip of this ultrasonic tip never is directly against the tooth. If it's directly against the tooth, it can gouge the tooth and the tooth root. So that's why we want to make sure that it's away